Good afternoon. Welcome everyone, and I'd like to welcome all of you to our October Global Health Tuesday webinar. We have named this one Vaccines, Immunization, and Fake News. I'm Jorge Osorio, Director of the Global Health Institute that will host this series, and I'm delighted to welcome our distinguished panelists and all of you to what I think it will be a really excellent discussion. Our Global Health Tuesdays features researchers and practitioners from the University of Wisconsin-Madison and across the world. The speakers showcase the complexity of global health challenges and the many kinds of expertise that are needed to address them. By sharing their experiences with the campus and Madison communities, these guests provide insights into global health, encourage conversation, and help connect colleagues locally and globally. We would love to see you in our next webinar on December 6th, in which we'll have our discussion on the One Health centers in Colombia, Sierra Leone, and India. And to receive more information, please look into our website, ghi.wisc.edu. So our moderator today is Dr. James Conway, who is the director of the Office for Global Health in the School of Medicine and Public Health, and he's also a member of GHI's transition team. Dr. Conway is a pediatric infectious disease specialist who works both domestically and globally with programs designed to improve the lives of children. He has been involved with long-term field programs in Thailand, Kenya, and Ethiopia, and he also has worked across the US to improve immunization accessibility. So please help me to welcome Dr. Jim Conway, who will introduce our panelists. Thank you, Jim.
Thank you so much, Jorge, and thanks everyone for joining us. It's great to see so many familiar names and faces here on the Zoom platform. Before I introduce our speakers, I just wanted to briefly sort of put a little bit of this in context as we think about this. You know, I think just setting the landscape and acknowledging that immunizations, without any question, have been probably the most important public health achievement that mankind has ever achieved, saving more mortality and morbidity amongst the human race than any other public health measure. I think we also need to understand that this idea of vaccine hesitancy, while it dates back well into the late 1700s when Edward Jenner first immunized little James Phipps with smallpox and people questioned that this has been an ongoing issue to the point where it was actually finally added by WHO in 2019 as one of the top 10 global health threats, preceding the COVID pandemic that we've dealt with. And so this was even on the landscape of a threat prior to that becoming the major issue that we've been facing for these last few years. And as we feared throughout this pandemic, millions of children have missed out on important routine vaccines. Early in the pandemic, the estimates were literally over 100 million kids were going to miss out on measles vaccine. And around the early part of the pandemic, as we started to see what was happening for routine healthcare in the United States, some of my research team put together this projection, which basically looked at the first 6 months of drop-off in well children visits and calculated that we were going to need to achieve somewhere between 5 and 15% greater immunization rates on a regular basis just to be able to keep up and actually catch up with everything we were missing. Little did we know that this vaccine hesitancy has really spiraled out of control. And not only have we continued to lose ground, but we've actually continued to lose ground in multiple areas. And so as I feared, and as many people projected, measles has once again reared its ugly head. And in the first few months of 2022, WHO and UNICEF really clearly articulated that these outbreaks were already starting to happen. This is data from WHO just a couple of days ago showing where we are seeing measles outbreaks that are cascading across the globe. And as many of us saw just a few weeks ago, reports of reemergence of measles just across the border in Minneapolis. So without question, this is a very timely topic, and I'm really privileged to have such a great panel of speakers. I'm going to start out with a tag team of Paul Hunter, who's going to be speaking with Hannah Segaloff. These are two people that are pinch hitting after one of our speakers got stuck in transit due to airline issues, which many people have been experiencing recently, unfortunately, and really grateful for both of them stepping up. Paul Hunter is an associate professor in the Department of Family Medicine and Community Health, as well as the associate director of the Wisconsin Academy of Rural Medicine and the director of the ambulatory acting internship for our students. He served as associate medical director for the City of Milwaukee Health Department from 2009 to 2019 and continues to be a consultant for both the city and the state. He also has worked with underserved patients in the federally qualified health centers and was a voting member of the ACIP for some years. He's been a great colleague and a great friend throughout these years as we've worked to try to improve vaccine access and working on vaccine policy. Hannah Segaloff is a PhD and an MPH, also a lieutenant in the US Public Health Service. She's a career epidemiology field officer with the CDC, who's currently working with the Wisconsin Department of Health Services. And we really value her expertise as she'll contribute some really important information to this conversation. So Paul, I'm going to turn it over to you and Hannah to start off, and then we'll move to our next speakers after that.
Sounds great. And can you hear me?
Yep.
Great. Let me get everything set up. So I'll be talking about measles containing imported cases as childhood vaccination rates decrease. And those are the two parts of what I'll be talking about. And Hannah will talk sort of in between those about some specifics about her role in containing imported cases. Let me see if I can go forward here. There we go. So measles has been decreasing since the vaccine got started in 1963. And then in 1989, there were outbreaks that resulted in the ACIP adding a second dose of MMR into the childhood schedule. And in 2000 in the United States, there was no more continuous transmission for up to 12 months. I'm sorry, over 12 months in the United States. And I think we've just been squeaking by at keeping that elimination since then. In particular, in Wisconsin in 2021, there were 22 cases of measles reported in Wisconsin. They were all in evacuees that were isolated on a military base. And this is a report of that from the Wisconsin Department of Health Services that Hannah was involved with, the measles outbreak associated with Operation Allies Welcome at Fort McCoy. From the first case detected on September 5th through October 8th, 2021, there were 22 cases among the evacuees. And thanks to Hannah's and others, people's efforts, both at the federal, state, and local levels, there were no cases in the community. The broader perspective on this nationwide were that the case in Wisconsin was the first that was identified and triggered a national increase in measles surveillance, case investigations, contact tracing, and mass vaccinations, both overseas and domestically at military bases and a hotel. And from August 29th through November 26th of 2021, there were 47 cases total related to this evacuees that were detected, 22 of which were in Wisconsin. And there were over 72,000 evacuees that were involved. So it was way less than 1% of them. There were no cases that reached outside of the bases or that hotel where the evacuees were housed. Some of the activities involved in controlling this these measles cases were related to flights and mass vaccination. The flights of the Afghan evacuees first began arriving in the United States on August 17th, 2021. Between August 24th and September 24th, there were MMR and varicella vaccination activities occurring. The day after the Wisconsin case was reported on September 6th, 2021, there was a significant increase in the mass vaccination efforts that occurred. And 4 days after that, and on the 10th, flights were temporarily halted from overseas into the United States. And 4 days after that, on the 14th, the CDC directed that the overseas bases where the Afghan evacuees were staging were to quarantine the evacuees for 21 days following receipt of MMR vaccine. And this is actually something I've seen in a case that we dealt with in 2011 in Milwaukee, and I can talk about that later if you're interested. That is temporarily halting flights of, say, refugees and vaccinating at refugee camps. On October 5th in 2021, flights resumed, and that was basically 21 days after the directive was started. They started resuming the flights. And then on October 15th, 2021, there was the last case, the rash onset of the last case of the 47 that was identified. And at this point, I would like to stop. I'm going to stop sharing so that you can see Hannah a little bit better, and I'll reshare my slides after you talk, Hannah, a little bit more about your activities at Fort McCoy.
Yeah, thank you. So just wanted to provide a little more detail into kind of what that response looked like, because having that large of a, I think, measles outbreak domestically or somewhat domestically is an unusual thing to occur. So just as Dr. Hunter mentioned, flights with evacuees began arriving in mid-August, and these Afghan refugees and SIV holders or SIVs were sitting in Germany briefly after they were evacuated from Afghanistan, and then entered the United States in Dulles, and then came to the different bases where they were going to go to. That all happened relatively quickly. And the way that this looked at Fort McCoy, which was one of the largest bases that eventually had between 12,500 and 13,000 guests, was that they arrived, and it was hundreds of people arriving a day, kind of going through this very quick screening process, getting their information, getting what they need, and then going to kind of living in barrack style housing. And this was obviously, people were very tired. They had just traveled and very emotionally tired as well. In addition, people were assigned places to live, but many people had family members that maybe were assigned somewhere else. So people were moving and crossing and moving to different places and walking across this large army base. And it was very difficult to identify people at first because most people had lost their documents, and there's, many people didn't speak any English, and there was a kind of lack of translators as people were still coming into the base to figure that out. So it was a very challenging situation to work in, and the first measles case ended up sitting in a hangar in Germany with many people that went to all the different bases. So as you can imagine, that situation was ripe for kind of dispersal of measles. So at Fort McCoy, I think the story was very interesting because it really shows the power of vaccines. We had that first case, the ability to isolate and quarantine was very tricky because, as you know, as you heard, many people are all mixed together, and we were at capacity of the base. So they were able to find some alternate locations for folks who are ill, but there wasn't really an ability to quarantine folks. So for that reason, mentioned, all the flights were halted, which was not a popular choice at first, but I think everyone was very happy that that happened. And people were vaccinated immediately, and we really saw that typical, 10 to 14 days after that first case, we had a few cases. On the next kind of zero interval, we had some more cases, and then it completely halted, as you could see with the power of the vaccines, where 96%, I think, of guests were vaccinated. Everyone, it was a requirement to receive MMR at that point to leave the base if you were eligible or didn't have proof that you had had a vaccine, and the outbreak kind of stopped from there. And a lot of our efforts included kind of making sure that people who are working at the base were vaccinated, offering them vaccine if they did not know if they were vaccinated, and monitoring in the community to make sure that this didn't leave the base. I'm happy to talk more about that later.
Thanks, Hannah. I'll get restarted and go to the second part of what I was going to talk about, which is vaccination rates in Wisconsin children by age 24 months have decreased over the past 8 to 9 years by 6% for MMR, down probably to below what would be a level that would stop ongoing transmission. I think 85% on a population-based level is probably what you're looking at as a sort of cutoff. Generally speaking, Jim Conway may have comments on that. On a census tract by census tract level in Wisconsin, in Milwaukee in the 80s, they showed that you could actually get down to 80% and still have pretty good coverage at that point. Polio similarly has decreased over the past 8 years, which is obviously another concerning infection that we want to could be imported and has been imported recently. School immunization rates, requirements for school entry at kindergarten, I think, or first grade, I forget which it is, and then in the middle school ages. These requirements are not just having been vaccinated, but also include having a waiver or being in process to getting caught up to the schedule. So that when you see that the met requirements is about 6 points higher, maybe 6 or 7 points higher than what the vaccination rates are for MMR and polio, that would make sense, given that our waivers are in the 4 to 5% range and the in process is in the 1 to 2% range. And the more recently, or the past couple of years through the pandemic, the school immunization trends have really stayed very similar as far as waivers, both all vaccines, personal waivers on particular ones, religious and health. It's really the behind the schedule that has been the issue, and that is not as much of an issue of hesitancy, but possibly of access and comfort level with seeking care early on in the pandemic, COVID pandemic, and now just trying to get caught up and getting an appointment at your family doc or pediatrician's office. So the behind the schedule went down by 1.5%. So that is what is happening most recently. And then as Jim referred to, in June through September of 2022 in Minneapolis-St. Paul, there were 13 cases of measles in several different families, in unvaccinated children that had traveled to different countries that have higher levels of measles going on. And so I think that's why this session we're having here about the importation of measles or polio, or take your pick of vaccine preventable disease into the United States, has two parts to it. One is the high rates in areas outside of the United States, but also our lower vaccination rates that are continuing to slowly decline in the United States that could set us up for larger outbreaks. So what a wonderful place to stop. I'm going to stop sharing and let Jim introduce the next speaker as soon as I can get a control here. There we go.
Thanks so much, Paul. Thanks so much, Hannah. Really interesting piece of the story. Just as a quick aside, for those of you that are going to be interested in participating in the discussion, please put your thoughts and comments and questions in the chat, and I'll be reading those later as we get to the panel part of this discussion. And just a reminder to please keep yourself muted if you're not speaking. Next up, Ambassador John Lang is a senior fellow for global health diplomacy at the United Nations Foundation, as well as a member of the Global Health Institute Board of Visitors. Ambassador Lang had a distinguished 28-year career in the Foreign Service at the US Department of State, where he was a pioneer in the field of global health diplomacy. He's an author of a case study on pandemic influenza negotiations, has delivered numerous lectures, and writes a blog on global health issues that I encourage people to seek out. It's really interesting, and has served on global health and security committees of the US National Academies of Sciences, Engineering, and Medicine. He currently chairs the leadership team of the Measles and Rubella Initiative, and earlier served as the co-chair of the Global Polio Eradication Initiative, a Polio Partners Group. So without further ado, Ambassador Lang, over to you.
Thanks very much, Professor Conway, and also thanks to Professor Osorio and the Global Health Institute for inviting me today. I don't have an MD degree. I don't have a master's in public health, unlike all the esteemed panelists. But there is a connection between those health issues, the public health issues, and national security issues and traditional areas that diplomats deal with. And to prove that, in a sense, let me just point out what President Biden did today. He signed a national security memorandum called National Biodefense Strategy and Implementation Plan for Countering Biological Threats, Enhancing Pandemic Preparedness, and Achieving Global Health Security. And it talks about infectious diseases that cross borders and disrupt societies, are a threat to our national security and global stability. COVID-19 is the latest example of how biological threats can devastate communities across America and around the world, resulting in millions of deaths. And trillions of dollars of economic losses globally. In addition to COVID-19, the global community is concurrently fighting outbreaks of monkeypox, polio, Ebola, highly pathogenic avian influenza, and other diseases, stretching thin global resources and demonstrating gaps in our current preparedness, and the risks of weaponization of biological agents are expanding. So here you have, I think what you can just see from today, an interest on the part of the U.S. federal government at the highest level, the president having signed this national security memorandum that really makes a connection between the work that is done on public health issues and U.S. national security. And in fact, in reading some of the details of this, one of the goals for any future pandemic in this national security strategy is that within 100 days of the beginning of a pandemic, a vaccine will be developed. So it really is an ambitious new strategy. What I'd like to do briefly is to talk about some of the diseases and the vaccines that go with them that we've been talking about in a global context, because I work at the UN Foundation based in Washington, D.C., and I have dealt with these, as you heard from Professor Conway, in a global basis. First, polio, then I'll talk about measles, and then I'll talk about the new Immunization Agenda 2030. On polio, I've been working on this since 2019 when I first joined the Bill and Melinda Gates Foundation. It's Bill Gates' highest priority, and great credit, I think, has to be given to the Global Polio Eradication Initiative, which was started by the World Health Assembly in 1988. At that point, 350,000 people a year were paralyzed from polio. Now, so far in 2022, as of last week, it's down to 29 confirmed cases of wild polio virus type 1. Almost all of those were in the endemic countries, Pakistan and Afghanistan, where sadly wild polio virus has never been eliminated. And there's been huge progress here. But the problem now at the end of this program of eradication is they're dealing in some of the most difficult places on earth. You just heard about the Afghan refugees who came to Wisconsin. Well, polio is still in what is now Taliban-controlled Afghanistan, and it's in some of the most remote parts of Pakistan. They're very difficult places to work. And then there's another aspect of this called circulating vaccine-derived polio virus. That's when immunization rates are so low in a community that the weakened virus from the oral polio vaccine ends up spreading through sewage, wastewater, uninterrupted for a long period, and then mutates into a virulent strain. They call it vaccine-derived polio virus. And sadly, in areas where there are low immunization rates, this has now come about that there's been this circulating vaccine-derived polio virus, including the first U.S. case in nearly a decade that occurred in Rockland County, New York in July. There have been also detections in sewage wastewater samples in the United Kingdom, as well as in New York. Now, this is scary, but it just shows the imperative of eradicating polio. We really have to finish the job. There is an innovative new tool that was created with a lot of effort funded by the Gates Foundation and others. It's a new vaccine called the novel oral polio vaccine type 2. It gives some hope. And there's a new strategy that has been produced by the Global Polio Eradication Initiative, GPEI. The thing is, this new strategy costs money to implement. They're asking for $4.8 billion for the period 2022 to 2026 in order to reach 370 million children annually with polio vaccines and other essential services. This morning, our time here in Madison, this morning there was a big pledging event in Berlin as part of what is going on there right now, the World Health Summit. And the various organizations and countries pledged over $2.5 billion toward that $4.8 billion that is needed through to 2026. So challenges remain, but we're really moving forward. And I think these recent cases and the recent outbreaks, including in the United States, of circulating vaccine-derived poliovirus has really brought home how we have to finish the job, even though it's difficult in those last stages. You've heard a lot about measles. The sad thing is, due to the COVID pandemic, the first dose of measles coverage dropped to 81% globally in 2021. That's the lowest level since 2008. That means that almost 25 million children missed their first measles dose in 2021, and that's over 5 million more than missed that dose in 2019. So COVID really has caused a serious problem. And I chair the leadership team of the Measles and Rubella Initiative. That's an initiative that involves the American Red Cross, U.S. Centers for Disease Control and Prevention, UNICEF, the UN Foundation, and the World Health Organization. And again, just as in the polio case of the drastic drop of cases since it was created in 1988, if you look at what happened with MNRI, the Measles and Rubella Initiative, the number of estimated measles deaths has decreased 94% since it was established in the year 2000, from over 1 million a year to 60,000 deaths in 2020. And I want to give credit here to our moderator, Professor Jim Conway, who has been an active supporter and participant in meetings of the Measles and Rubella Initiative. Now, what we're doing in that Measles and Rubella Initiative is to work with, beyond those 5 partners that I mentioned, work with Gavi, the Vaccine Alliance, and the Bill and Melinda Gates Foundation to improve measles programs, and to do this as part of something that's really exciting on the immunization front in the global sense. Do this as part of Immunization Agenda 2030. It was approved by the World Health Assembly, and it is moving forward now. The idea is to have this broad effort that's going to look at immunization systems as a whole, not just disease-specific initiatives, because it's clear to everyone that you can't solve the problems by just having a vertical program, as they call it, focusing solely on polio or solely on measles. You really need to improve the immunization systems as a whole in low and middle income countries in particular. And that's part of a broader effort for universal health coverage and strengthening health systems as a whole. Immunization Agenda 2030 was developed as a bottom-up co-creation process. It involved the engagement of countries to ensure that its vision, its strategic goals, and its priorities are aligned with country needs. And it's really an exciting new initiative, and because of the way we in the Measles and Rubella Initiative see this moving forward, and because of the importance of this broad approach to immunization, we're going to be working very closely with them as we transition to what is called IA 2030. So there are great challenges out there, but if you look at just the success this morning of the pledging event for polio, which went a long way toward giving them the money that they need by the year 2026. When you look at the Measles and Rubella Initiative working with Immunization 2030 and this broader effort, I think you can look with a lot of optimism on the future of immunizations and vaccines globally, and the likelihood that many fewer people will die of vaccine preventable diseases as these programs progress. Thanks.
Thanks so much, Ambassador Lang. Really great stuff to think about as we move to our last speaker before we open it up for discussion. And Dominique Brissard is a professor and chair in the Department of Life Science Communication in the College of Agriculture and Life Science. Her research agenda really focuses on the intersection between science, media, and policy. And so I think you can see why this is such an important aspect to this conversation as we try to figure out how do we actually message and communicate these important ideas to the general public. She's a fellow of the American Association for the Advancement of Science and on the International Communication Association. She's an internationally known expert in public opinion dynamics related to controversial scientific issues, which sadly vaccines have become, unfortunately. She's particularly interested in understanding the role of values in shaping public attitudes and using cross-cultural analysis to understand these processes. She's published more than 100 research articles and has been an expert panelist for the National Academy of Sciences, Engineering, and Medicine on various occasions. So Dominique, I will turn it over to you and you can take it away. I believe you should be able to share if you have slides you want to share.
I was trying to mute myself, but I was told that the host was doing that for me. So thank you, host, for allowing me to speak. And I won't have any slides, actually, because I think that I wanted to complement very nicely what the other speaker have said this and kind of come back to what you open us up with, Jim. So as mentioned by Jim, I'm a social scientist, I'm a communication scientist, and model public attitudes and behaviors related to controversial science issues. Most recently with the National Academy of Science, I was a part of a group that was fostering the use of scientific evidence in response to COVID-19 related behavior. Basically, we're doing rapid expert consultation report to actually build on what we know from social science to encourage different behavior. And the reason why I mentioned that is because we did 2 reports related to COVID-19 vaccine, helping policymakers on the ground, put together campaigns. And the reason why I'm saying that, and I'm saying it comes back to what Jim was saying, is because there's a lot that we know already about why people react a certain way when we tell them to do things that they don't want to do. And indeed, vaccines have been controversial since their inceptions for various reasons, although immunization in themselves, as we know, in the history of times have been, around with us for a long time, the first one being, monks inoculating themselves against snake venom to be resistant to snake bites. Vaccines in themselves, the way we think about with public health in programs mandated by governments, really, have been introduced in Britain in the 19th century. Right away, controversial protests and so on, that were, basically, I would argue, being fueled by the idea that it was required and mandatory, and then also by fear of the unknown. I teach a psychology of risk, which is really basically the idea of why do people get scared of certain things? And we know that most likely it's based on dimensions that have little to do with scientific evidence. It is due to concerns or other dimensions that literally, unfortunately, scientific evidence has a hard time countering. So in a nutshell, going back to what we were saying at the beginning, understanding why people react a certain way is basically a social science question. I'm so glad that the Global Health Institute includes so many different affiliates coming from different disciplines. And I'm very grateful for Jorge and others at GHI for organizing these platforms where we can discuss how all our approaches together can solve very important issues. So history of vaccines resistance is long as vaccines themselves. And, the fact that we have been studying them for a while is also a plus. So what has changed? And can we say that misinformation in itself is causing, to some extent, the potential, resurgence of concerns with vaccines? The reason why I use the term misinformation is because I actually talked to Jorge about this and saying that the notion of fake news to some extent was really used in a political context that I think does not really apply here. I think we should talk about either misinformation, that people get information that's incorrect, or disinformation, the idea that actually some people do it with a goal in mind, disinforming with the goal to actually disinform. And that's an important criteria to keep in mind, because I would argue that since the 1980s, what has been clearly evolved in the anti-vaccine movement is the power that the anti-lobbying vaccine has gained with, number one, endorsement of celebrities, and one of them is Jenny MacArthur, for example, that have been amplifying the world of those disinformation. And number two, obviously, the advent of social media that allows groups that think alike to gather and, and being able to build forces to actually counter what we would not like them to do. However, and I think like our speakers, Hannah, Paul, and John, sorry if I use the first name here, I'm Latin, we use always first name when we talk to people. Sorry if it's not very authoritative here. So has shown that, we should be careful about trends, but however, it's not catastrophic yet. So the idea is we should actually make sure that we understand if there is a problem, where it comes from. I think it is clear from a social science perspective that we are all causing the problem, with COVID-19 being on top of the iceberg as far as exacerbated problems that we may have. Number one, misinformation in itself is a problem if it's amplifying through media channels. Unfortunately, what makes something newsworthy is something that has magnitude, that produces dread, that has consequences, and so on. It's much easier to some extent for journalists to report in an isolated death that may not be at all due to vaccines, by the way, but framing in a way that actually raise their magnitude, that write again and again something that Jim said at the beginning, and John also said, all of us actually, that vaccinations and their results is one of the most, phenomenal public health program that we've ever been put together across the world. This is not a story, unfortunately, because you tell that story once, you don't repeat it again and again. So our role is actually to do workshops with different health communicators to make them understand that they need to repeat that again and again in their stories, that they cannot do just episodic event coverage about one case without forgetting about the whole thing. So this is the important thing about the journalism. Number two, how do we deal with celebrities? Well, one thing is that you don't amplify their voices. And very often I see it in Twitter again and again, we retweet something we think is wrong by saying, look how wrong it is that this person does that again and again. By doing so, we just give voice to those that we want to actually make sure keep quiet. And certainly what we do is give blood to the reality of today's world, which is algorithm news. Algorithm will be the power of dissemination and so on. We've been actually arguing with our colleagues at Big Ten to give us those algorithms so we can study in. But for sure, what fuels algorithm is the likelihood of people sharing them. The more they share, they will share it again. The likelihood of people being angry by them, the likelihood of people comment on them, and so on. So I would urge all of us in the global health community to understand social media dynamics, to make sure that we counter those powers, because I would think that this is one of the things we should be more worried about worldwide. And I'll stop here. I just wanted to give some pointers for further discussion.
Thank you so much, Dominique. Really interesting conversation. So for people that want to contribute, please put your questions and comments in the chat. I've already got a couple that people have sent over to us ahead of time, so we'll get started while people are thinking. So first off, I wanted to ask Hannah something very specific, which is the messaging that was given to the Afghan visitors and how this was explained to them as they were lined up and required to get these vaccines. What kind of information and how was that done, do you think, to make this an effective response?
Yeah, I don't want to speak too much outside of my knowledge because all of the legal proceedings and things like that are very complicated and we're unique in this situation. But actually, so some of these vaccines, particularly MMR, was actually already a requirement. The thing that I think, and while people were counseled, and I'm sure people had the chance to decline, they had to receive a certain set of vaccines based on age to be resettled and continue with the program. So so that was a pretty strong incentive in that case. I think a lot of the communications had to do with why they had to receive all these that vaccine particularly right now, and you know, why resettlements were halted, which was certainly not something that people were excited about. But as part of the resettlement process, there was a medical medical visit that happens overseas generally that was happening in the United States. So that was a requirement anyway. So not too much. I myself was not involved in kind of any of the counseling, but I think because of those kind of other forces, most people were happy to receive a vaccine. And also, I mean, people were aware of measles and other diseases that were spreading and certainly did not want those to impact them or their family.
Great, thank you. Ambassador Lang, one of the things that people have wondered about is when these diseases are common and when they're on the front page of the newspapers, it's probably a lot easier to get commitment and finance and the attention of policymakers. How does that change as these diseases become less common, but are still out there and potentially can reemerge? How did those conversations change at a policy level when you're in the circles that you travel in?
Actually, the conversations continue quite well. I think it may be different at the community level in terms of whether a mother is worried about polio when she doesn't see any cases of polio because there are very few cases. But on the national level in the United States, for example, Rotary International, one of the 5 core partners and now 6 core partners with the addition of Gavi of the Global Polio Eradication Initiative, has a very strong advocacy arm in Washington. They have Rotary clubs in every congressional district, and they really have, prior to the pandemic, they had an annual reception, and it was just amazing. I attended this every year, and you would have about a dozen members of Congress, both representatives and senators from both parties, come and speak. They would come into the room, give their speech, and then leave. Sometimes they were giving the same speech because you could tell Rotary provided them all with the same talking points. But on the whole, it's really something that has kept up, and the U.S. government did even today pledge $114 million toward this global polio eradication initiative pledging moment. But you know that the way the U.S. budget works, more will come. They can't pledge for years beyond the current fiscal year. The same with Bill Gates. I traveled with Mr. Gates to Chad to meet with the president of Chad, President Deby. I traveled with him to Nigeria to meet with the then president of Nigeria, Goodluck Jonathan. When I was working at the Bill and Melinda Gates Foundation, he has maintained that. And today at this global polio pledging event, the Gates Foundation pledged $1.2 billion over the next 4 years through 2026. So there is not a lessening on the part of the U.S. government or foundations. There have some countries where there's a bit of a lessening of support from some of the other donor governments. But I think in the long run, you're going to find that GPI will get the money that it needs for polio in the years to come.
Great. I love your optimism. It always makes me happy. Moving on, Paul, if you can just touch on something that you and I both touched on, which is why has COVID caused such a big decrease in childhood vaccination rates? You and I both briefly touched on it, but I think you can elaborate a little bit more.
Well, the pediatrician's office is basically closed down for a few months. That's about the short of it. And then when they started back up in family docs, clinics consolidated and saw a lot less people in person. I'm not going to blame all you pediatricians, obviously. I'm sure you'll get back at me somehow if I do, as a family physician. But anyway, so that built up a deficit that, as I think you explained in your modeling, if I understood your modeling correctly, would take a long time to recover from. So that's the bottom line there.
Yeah, I think the other part is that there was probably some perception, and this will go to Dominique in a second, that since it was okay to cancel these appointments and it was okay to not vaccinate for such long periods of time, there did become this perception in some of the general public that maybe these weren't as important as people had been saying they had been all those years, because why else would we allow them to get off the hook for extended periods of time when the medical systems were not able to deal with the capacity, which obviously was a piece of misinformation, but unfortunately it has cascaded. So Dominique, the big question and the number one question that popped up here is, how do we fight this information? It goes at the speed of light. What kind of recommendations do you have for how do we manage it when it does get out there? Besides just not retweeting and amplifying it, how do we actually combat true disinformation and misinformation?
Well, I would step back a little bit, Jim, and actually argue with you about something you just said. Actually, most of the research that was done during COVID-19, although the media coverage tended to be very polarizing and so on, tend to indicate that the main reason people were not vaccinated was for lack of access. And to go back to what Paul has saying here about measles and so on, I mean, we don't have evidence that say that people think they've been left off the hook and therefore they wouldn't vaccinate their kids. Some anecdotal evidence, maybe a few people here and there have said that. So to your point, that we have heard that, but overall, it's not a pattern that seems to hold. Overall, there is really still the open question here on how much this information itself is really leading people not to be vaccinated. So what we know is there's pockets of resistance among communities, and measles was, the different measles outbreaks that we've seen in the United States, over the last 2 years, show that it's actually really much more something related to values. So something, for example, in California, people that were trying to, against big pharma, that notion big pharma works with the government, that they want to actually insist on natural elements for their kids and so on. So a whole bunch of values that you could claim are, maybe, amplified by disinformation, but it's more symptomatic of something else. So it's really something that the information may confirm their belief, and we have a whole thing in social science that we call confirmation bias or motivated reasoning and so on. But a lot of people will tell you that actually there's a scientific study that confirms what they think. Well, unfortunately, that study very often is not something we would consider trustworthy science, but in their head it is. I mean, the infamous Wakefield study that supposedly linked vaccines to autism and so on is still brought up again and again in public meetings when we talk about vaccines. And so people generally think this is science. So the disinformation itself is maybe that we should think about how we talk about science in public school, teaching about the process and how we end up having, results, what it means to be a retracted study and so on. So it's not about just the fact that they bring up, is why they believe that this is something that's worthwhile thinking about. So I think it's very important. The second thing we haven't talked about is because it's who actually potentially disseminate that disinformation. We need to know that right now in the United States, we do have a general, decreasing confidence in general. So we know that there is a decrease in trust in public health in general, which is too bad because our local public health experts, usually are very highly trusted. But this is actually lack of trust, about police, about school district, about everything. So we think that this is more linked to post-pandemic general anxiety levels, where people experience what we call the pandemic fatigue, and they are a little bit, excuse my English, fed up with everything. So how can we restore trust in the system? I think is for something for us that we need to ponder. I have a lot of trust, and actually seeing Paul and Hannah here is really, earthwarming, like in the case that like they are there talking to the community, they are talking to people in a way that will restore our trust, I think, by convincing people again that the local public health experts do have the community well-being in mind. So I kind of twisted your answer, because I think fighting disinformation itself is not the goal that we should have.
So then that turns it around to one of the other questions that was posed here, and I'll let everybody take a crack at this, which is that, you know, the ability or the tools to address vaccine hesitancy in individuals and in families have largely been designed to be used at the individual clinicians' one-on-one conversations with those families. And, you know, those have certainly been moderately successful at some level, but obviously time consuming and exhausting. And so one of the big questions people are wondering about is, are there other venues or other avenues for sharing more accurate information to try to combat vaccine hesitancy that we should all be thinking about, beyond just putting all the burden on our primary care individuals? So I'll let everybody sort of take a crack at how else they think we might be able to take on vaccine hesitancy. Paul's got his finger in the air, which means he gets.
I'd like to go first and follow up on Dominique's comment about access being the main thing. And I think that systemic issues within the clinical setting interfere with getting as many vaccines out as they can. I mean, it's sort of ridiculous for me to say this, but if you could have evening hours or more convenient hours and staff or your clinic in a way where you could vaccinate when people aren't at work and have their children under their care, that would make a huge difference. And that is extremely difficult to do in a lot of situations. But I think access is a big issue. So I'm sort of talking of getting the people where convenience is more of an issue rather than hesitancy, because I think that could shave off a significant portion of the problem. One issue is just knowing whether or not you're up to date on your vaccines, and having community health care workers go out and just look up their Wisconsin Immunization Registry information to say, hey, you're due for these shots. Go and here's how to make an appointment to get those taken care of. I think that could make a huge difference. So I think I agree that physicians and other clinicians need to know how to talk, and it's more how to listen than to talk. But I don't think that's going to do it by itself. And I definitely think that retweeting something is the wrong thing to do. Do a screen capture so they don't get the credit for what you're sending on.
Ambassador Lang, do you have any thoughts on the global scale, how we can get more accurate information in front of people beyond just leaning on the clinicians?
There are efforts going on, and in fact, that's built into the new polio strategy to have new ways of communicating. UNICEF is a leader in this at the community level. One of the problems that polio is encountering right now, it's not hesitancy. There has been some of it, but not hesitancy quite in the way we've been talking about by the anti-vaxxers. But instead, it's a low priority for so many families to be eradicated, to be vaccinated against polio when you have all these other things to worry about. I used to chair the Polio Partners Group of GPEI, and I remember one meeting where an expert who's worked with a lot of non-governmental organizations in low-income countries on polio said that he thought that the average mother, when asked about a polio vaccine, would put it for her children, would put it number 10 or 20 in the list of priorities, after diseases that are more present, after need for water and sanitation, food security, et cetera, et cetera. And one of the things that GPEI is finding as it gets to the very end of its effort to eradicate polio with that last 0.1% of cases to deal with, it's finding that it can't just do it alone in that vertical sense that I was mentioning earlier. It has to be part of a broader effort to provide water and sanitation improvements, to provide broader immunizations against diseases that are seen by the populace in the community, so that it can overcome some of that reluctance that it's encountering. One other thing I need to mention, I think, is Professor Heidi Larson heads the Vaccine Confidence Project based in London at the London School of Hygiene and Tropical Medicine. And she's done a lot of excellent work on this. If anybody wants to look up the Vaccine Confidence Project, it's done some great work on this subject.
Yeah, great reference. She's wonderful, and her team has really done some remarkable work. Dominique, I'm going to throw a sort of a last word to you. One of the things that people sort of wonder about is when you're trying to I wouldn't say argue, but discuss with people that are vaccine hesitant, there's a disconnect sometimes, or a balance in trying to impress upon them the nature of the diseases and how scary they are, versus the idea of them taking the risks that they perceive around vaccines, and this heuristic thinking that people go through of what are they more afraid of? Are they more afraid of the disease, or are they more afraid of the vaccine? And lots of people get asked their opinions, whether it's in their neighborhood or at their church or school, about these kinds of things. And I just wonder what your take is on, when you're trying to have one of those conversations, what ends up being the thing that prevails on people as they make their decisions, being afraid of the disease or being reassured about the safety and the benefit of the vaccines?
That's a great question, Jim. And I always say in my risk communication class, I always say when experts think in terms of risk, the public think in terms of safety. So if you tell a mom that there's one chance of 1 million that there was going to be some side effect for a kid, for you, it may be very low. For the mom, it may be, what about if that one is my kid? So that's the idea. So it's really like about the safety. But going back to your question about how to approach this in a way that doesn't put the burden on the public health community. I mean, John mentioned the work at UNICEF. WHO has been doing actually really good job on the work on the ground also by enlisting what we call local public opinion leaders, people in community that are trusted, that are not the medical doctor and so on. Even in United States, there's been some success in New York City working with rabbis in Orthodox Jewish community to try to work with them as far as like enlisting the community members. So like thinking in terms, who else do people trust to talk about that in terms of hesitancy? But at the end of the day, it's really, I feel like communication really comes to listening, understand where people are coming from. And I think us in academia, unfortunately, we're not really taught to do that. We tend to actually profess and think people are going to listen to us just because of whatever, I mean, titles or so on. But, and as a matter of fact, it's really enlightening to listen to people because you learn a lot of things. And you learn that, they may actually react in a certain way because of very genuinely rational reason in their mind. So the fact that we are saying it's either rational or not rational, to some miss the point, because the decision-making process very often doesn't match what we think. So I think listening, and actually I'm very happy to hear that UW Health in their training for their doctors now, they have a whole communication skills where they learn to actually interact in a way that, that can react positive to somebody that says, I've done my own research, which is something that happens more and more.
Thank you so much. Well, it looks like we're at the end of the hour here, and I appreciate all of our speakers and everybody's contributions to this chat and discussion. I encourage people to continue to be part of these conversations, talk about what you and your family have done, normalize this idea that vaccination is the norm. I think one of the things that we had to deal with during the COVID pandemic was the hesitancy around that vaccine made hesitancy become something that was more acceptable and more normal. But I think the vast majority of people do believe, as has been said over and over again, that vaccines are important for them and their families, and that we all have an obligation and a real responsibility to continue those conversations and to continue to to amplify the normative behavior of getting yourself vaccinated and your kids vaccinated. You know, we don't want to backslide any further than we have. We've got a lot of catching up to do. And we've also got a lot of exciting new vaccines that are actually going to be coming over the coming years that are going to continue to change this landscape. I encourage everybody also to please visit the Global Health Institute website, where there's lots of information, including making sure that you tune in for the next webinar in early December. So with that, I'll close this down. Thanks again to all of our wonderful speakers, Paul, Ambassador Lang, Dominique, and Hannah for contributing. And thanks again for everybody contributing to the chat. Have a great day. Stay well, everybody, and please stay safe. Thank you.